So what we're going to try and do this evening is to rattle through. We'll see how long it takes. I'll hopefully try and keep it down to a survivable number with a bit of a break in the middle for us to get up and walk around if we want to. An overview of obesity, what it is, what causes it, what the consequences are of it, and what the current situation is with NHS treatment pathways for individuals with obesity. In order to do this, now if I press a button, look at that. Now, in an attempt to make my slides flashy, my 17-year-old, my oldest daughter, got hold of my slides yesterday evening and have flashed up Dad's slides because apparently black and white wasn't good enough.
Yeah.
We shall see what appears on the screen at various points. I don't think she's done anything she shouldn't, but yeah, we'll see how this goes, shall we? This could get embarrassing at various different points. Right, let's start with, now what I'm going to do to try and make this a little less dry and not just the academic story, but actually try and make this a little more focused on patients, is to make up a patient that we can then use as our fake patient that we can talk about throughout the evening. So I need a name for my patient. My patient, because it's going to come up later on, my patient probably needs to be female. So anybody want to give me a female name that isn't a name of somebody already in the room?
Agatha.
Agatha. Sweet. Excellent. So here is Agatha. Agatha is we go with, let's go with somewhere around 62 years of age. She has obesity, unsurprisingly, because that's what we're talking about this evening. Agatha is very overweight. Her current weight is 150.4 kilograms. I'm not going to give you a height, so we'll talk about body mass index in a minute, but that's a lot of weight. So that's where they are at the moment. Agatha has a number of problems because of this. These are around a whole variety of different issues. One of them is poor sleep. She's tired. You're going to read doctor's handwriting, I'm afraid. Sorry about this. Never gets any better. She's got a grandchild, recently born, struggling to care for them. She wants to be able to pick up, hold, play with a new grandchild. That would make sense, wouldn't it? Most 62-year-old new grandparents would want to be interested in playing with their new grandchild. She struggles with the housework and just generally moving. Oh, I can't. How are we going to do this bit? Oh, no. I'm going to try that later. And has a whole series of aches and pains. Nothing specific, just aches and pains that have never been diagnosed as anything other than aches and pains. We might add some more to this list as we go through. Agatha's clearly having a bit of a tough time of it. I've obviously exaggerated this for the purposes of the talk, but it makes a useful handle from which to move things forward. What we'll do is we'll move through a series of slides. It will help us to understand why some of these things are occurring in the moment, what other risks Agatha's running that she might not have worked out here. And then we can work out what we can do to try and help and make her better as we move through the talk. Does that all sound like a sort of handle to put things on? Yeah. Make it a little more personal. Yeah.
Can you convert that to 23.5 stone?
I have absolutely no idea what a stone is.
I know, but the audience does. Yeah,
that's probably a good thing, yes.
Yeah.
I am afraid to say I have always worked in kilos. My entire professional career, I have worked in kilograms. Everything is kilograms and centimetres. I am aware that imperial measurements do exist. I couldn't tell you how many ounces in a pound or how many pounds were in a stone. I genuinely don't know the answers to those questions because I have never worked in the imperial measurement. So if that's 23.5 stone, I will trust you, and we will go with that one for next.
Yeah, she's 20 feet tall.
Let's move on to, yes, I am exaggerating for the purpose of exaggerating, I thought. So I'm not quite sure how well some of this will appear on screen. Is that focused? It's not wonderfully, is it? That's a bit better, isn't it? Yeah. Cool. Anyway, let's go through a bit of an overview of obesity. I'll read it out so that we can get these anyway. First things first, definition. What is obesity? We've got lots of different definitions of this that float around in the medical press, but in essence, it is a chronic disease associated with the accumulation of excess body fat. That is what obesity is. In order to research that and to make medical improvements, you need to put a number on things, because you need an internationally accepted number so that you can compare studies and outcomes and treatments from one population with another. So we tend to define it as a body mass index. You may have heard of this phrase before. The body mass index is their height in meters squared and their weight in kilograms. But the weight in kilograms divided by the height in meters squared. The meters squared gives you the surface area of the body, and the kilograms gives you the weight. Hence the reason I work in kilograms, because that's the number system we use. Now, body mass index is a flawed number. It does not take into account, for instance, muscle mass. You can be incredibly lean with no added additional extra fat, but be extremely muscular because you spend all your life shifting weights around in the gym, and you will appear to have a high body mass index and appear to be overweight or obese according to the calculations. So it is not a perfect calculation. Patients who have, for instance, had a lower limb amputation have lower surface area, yet the body mass index does not take that into account. So there are some significant challenges with it. However, it has become the internationalized, normalized standard for discussing obesity. So that's the data and the numbers and the thresholds that we tend to use. And in terms of treatments, we have to translate the science into treatment that we use on individual people. And the body mass index is what the scientists have used. So that's what we've got stuck with. So whilst everybody will admit it's not brilliant, we'll have to kind of stick with it for now. As a general rule, a BMI of 30 or above is considered obese. 40 and above is considered, this is a terrible phrase that the scientists use, morbidly obese. Those titles are internationalized titles, not ones that we particularly like, but because they've become the internationalized titles, we tend to stick to use them because we have to use a similar language for communicating. It's not meant to be pejorative towards the individual patients. In the UK, about 64.5% when I checked last night with the most up-to-date data of adults in England, because I only have access to NHS England's and English population data. So 64.5% of adults in England are overweight or obese. 29% of them have a body mass index over 30, so are obese. So 29%, nearly a third of the adults in England could be categorized as being obese. There's a thing there. And in terms of a brief bit of impact, the numbers, again, I went digging last night. Difficult to put exact numbers from exact money pots on what's going on here. And I tend to have access to NHS information. We'll talk about the role of councils and public health as we go through as well. But for NHS information, we are looking at £11.4 billion worth of expenditure in England driven by obesity. That is not far off a penny on income tax. So this is a big, big cost to the way things are working in the UK. There is, at present, no comprehensive strategy in England for the management of obesity. There are bits of strategies in various different places. There are public health strategies. There are local strategies. And there is a bit that will come along, I'll mention later on in the 10-year health plan on it, but there is no single overarching obesity strategy. there is no junior minister for health for obesity. That person doesn't exist. So there's no responsible officer, there's no political leadership sat at the top looking at obesity as a single thing in and of itself. It gets split up into various different departments. So, causes then. Causes of obesity are generally split into three categories: biological causes, behavioral causes, and then psychosocial causes. Mainly because biologists study biology, and behavioralists and the sociologists study behavior, and then the psychologists study the psychosocial bit. So these have ended up being split up into three categories because academically, in the shiny copper-domed university bits that go on in Oxford, this will be split up into those three sections. So that's why it's ended up in those categories, because that is how research tends to work in England. So in terms of biological factors, there are genetic predispositions to obesity. There is no doubt that it is familial. It runs in families for a variety of reasons, but some of those are genetic. And we have found a number of major and minor genetic factors on studying that are clearly, at least in part, responsible for people being more prone to accumulate fat, thus become obese, than other people are. There are, and have always been known, some clear single gene genetic defects that result in biological impact that can cause increased weight. The classic big, this is really embarrassing now because I can't actually remember the gene deletion, but Prader-Willi syndrome is the one that is often stated, and we're not actually supposed to call it Prader-Willi syndrome anymore. I'm supposed to use the gene deletion name instead of that. But Prader-Willi syndrome is a disease that results in a genetic issue that results in a lack of satiety. So the individual feels constantly hungry all of the time. And because this is an inherited problem, they're born like this, the infants tend to eat and eat and eat and eat as they're growing up because they don't learn to not eat. So you end up with morbidly obese infants growing up into it's readily difficult to challenge a 2-year-old who doesn't know that they need to stop eating because they constantly feel hungry. And the consequences of trying to stop that are very challenging. We have at least one retired paediatrician. I'm not sure if you've ever dealt with children with Prader-Willi syndrome.
And they also have learning difficulties, which makes type control hard.
Yeah. It often coexists with some mild to moderate learning disabilities, which do go together. So we do know that there are some very clearly defined genetic influences in here. Hormone regulation also affects both the body's metabolism and the way we feel hunger. So hunger itself is driven by the release of hormones from your gut. You feel hungry because of those hormone releases. And a number of other hormones change the way you use energy and deposit energy as fat around the body. There are issues around leptins, some of the ghrelins. Cortisol is one of the key ones. Cortisol is a stress hormone, both produced by psychological stress and physical stress. So if you fall over and hurt yourself, your body releases cortisol to enable you to repair the damage that your body has suffered from. Those all cause significant increases in accumulation of body fat as a result of those hormone releases. Those hormones, of course, are also driven by genetics. So we now have an overlap between the genetics driving the hormones and the hormones causing some of the problems. There are also some specifically metabolic hormones that can have an impact on weight. These include thyroid hormones, for instance, where a lack of thyroxine, the hormone produced by the thyroid, will cause accumulation of weight until we have corrected that. And the opposite is also true. An overactive thyroid causes a reduction in weight. To that extent, individuals with eating disorders who are trying to lose weight will sometimes abuse thyroxine, drug that we use to treat people with underactive thyroids, to force weight loss on themselves. There's a resale value for thyroxine now on the secondary market. We're buying, non-prescribed thyroxine, non-force weight. a particularly silly way of producing weight loss because it has a number of other very serious side effects if you take too much of it. Behavioral influences. So, sedentary lifestyles, classic. A sedentary lifestyle, it will reduce the amount of energy you use up. If you are using less energy, you are putting more energy storage in fat and therefore accumulating fat. Our lifestyles in the United Kingdom and data is probably best from 1945 onwards, because firstly, the NHS was invented, so we've got data, and secondly, the Second World War and the interwar period skews the data massively when you're trying to study it. Our lifestyles have become less and less active as a society. There are, of course, individuals who do way more activity than others, but as a society, as a group of people, we have become less active. Our job roles have become less active and more sedentary in the way that we do them. So that absence of and that change in lifestyle has certainly been an issue. And the other behavioral influence is the increase in high calorie foods. Again, if you go back to the period immediately after the Second World War, of course, food was rationed. Still, food was rationed for quite some time after the war had occurred. And that naturally limited the amount of fats and sugars that you could get, because you had a ration book that limited the amount of fats and sugars you could get. You could get more than that, you'd be cheating a bit, but there was a limit on these things. So that only have changed significantly over that time, because now foods have, until relatively recently, been relatively cheap and easily affordable. You could make an argument about the current inflation in food that might actually not be holding up at the moment, but and what we have also moved towards is a food intake which is calorie rich and nutrient poor. The general diet has become higher in calorie and lower in nutrients. So what we have is an increasing amount of energy going into the body and a decreasing amount of the micronutrients and other nutrients that we need to sustain us. One of the problems of dropping the micronutrients is it pushes stress into the body. That pushes those cortisol levels up that we talked about previously, which causes you to gain more weight. So we've entered into a self-filling cycle with the foods that we eat, where the foods that we eat are short in nutrients, which is causing us to draw more calories out of the food and store it as excess fat. Which goes back to my previous comment about a national strategy for food. We will hopefully touch on some of that at the end, because there might be some moves in that direction. I am hopeful. Psychosocial and environmental factors. So I mentioned stress on a number of occasions. Stress is a thing. Now, stress has always existed. If you measure stress levels in the United Kingdom, they're not massively much higher now than they have been in the past. There was a dip in the 60s and the 70s. Apparently, nobody was stressed in the 70s. I think that's because they were all stoned. Apparently, if you can remember the 70s, you probably weren't there. So there was a dip in the 60s and 70s, but of course there was a lot of stress in the 40s and 50s, because the country was under a lot of stress at the end of the war and after the war. So our levels of psychological stress are not particularly that high at the moment. The problem is when you combine it with those environmental factors that I labelled above, that they're combining in a way which is making them more problematic. Mental health issues are another one that changes the way we eat. It can do both things. I mean, mental health issues can reduce the amount of food you eat. I have many patients whose mental health issues affect them, causing them to starve themselves. So it can head in both directions there, but there's certainly no doubt that some people change the way they eat because of their mental health. The only fuel your brain can burn is glucose. The brain takes glucose, adds oxygen to it, and burns that as the fuel that keeps your brain going. So if your brain is struggling because you have mental health issues that are challenging your brain and it's just not working as well as it should do, then the body will to some extent want you to feed it more sugar, more glucose, because that's what the brain thinks it needs to fix itself and makes itself better. That's the instinctive coding inside most mammals, but that includes human beings. So that's part of the issue that's going on in the mental health background now. There are also some issues around food insecurity. and costs of food. Now things are beginning to change slowly in the supermarkets, but up until recently, it was a lot cheaper to buy high-calorie, highly processed foods than it was to buy nutrient-rich, low-calorie foods. And there had been quite a discrepancy that had developed over time in supermarkets as people pushed the high-calorie load, highly processed foods through. That to the large extent is not gone completely, but if you look around the supermarkets these days, you'll begin to see that the price of some of those nutrient-rich and lower-calorie foods are starting to drop off. And there are also some other socioeconomic barriers. I mean, if you in order to acquire a range of food to eat, and we'll talk about diet later on, but in order to acquire the food you need in the diet, you need to be able to get to the food and be able to acquire it. It is not always easy for everybody to be able to. It's relatively easy around Faringdon, but when you go out to some of the villages around here, it's not always easy to get the foods that you need easily available. The delivery from the supermarkets is beginning again to shift this, because now you can actually go online and order your food online. The problem is when you put your order in Asda and you order up 12 bananas and they deliver 12 apples because they've substituted one with another, doesn't make it as easy as if you actually going around the shops and picking out the food for yourself. So online shopping is good. It helps, especially as isolated rural communities, but it's far from a panacea to the problems that we face. So any questions on the sort of causes and what is going on in the background there? No. Okay. Super duper. Let's look towards the consequences. And there will be a bit of an overlap here because some of the consequences will cause people to become more obese. Boo. So we'll talk about health risks first. We'll go down a variety of these, but we'll start with the obvious one, the health risks. So, the obvious one is that, morbid obesity or even being overweight for a long period of time increases your risk of type 2 diabetes developing in the individual. The vast majority of individuals with type 2 diabetes in the United Kingdom, certainly in England, with the data that we've got, are because of people being overweight, and it's well over 90%. There is a small genetic group of people from the Indian, Pakistani, Bangladeshi area where there is a genetic quirk in the population from that area which can result in having type 2 diabetes without the obesity. But that's a slightly odd variation to it. Certainly diabetes is one of the keys.
You did just say there's a familiar connection though for things like weight gain.
Yep.
Does that include diabetes in their familiar connection for diabetes?
Good question. Answer is not.
Because otherwise you're sort of saying you've got diabetes because you're overweight.
That is correct.
It may not.
Yeah.
It may not be just that.
No, you're correct. That statement is incorrect. You are correct. The statement is incorrect, if that makes sense. In that we shouldn't be saying you have type 2 diabetes because you're overweight. The correct phrase is you've got type 2 diabetes because you're overweight because of the genetics and the environmental factor in which you're living.
Okay.
And we're not taking that. We often don't take that extra step to it yet. There is, in the non-Indian, Bangladeshi, Pakistani community, there is no obvious direct genetic component to type 2 diabetes. It is a consequence of the weight gain, not a thing that is isolated to itself. So if those people lose weight, their diabetes gets better. Those people, say, who are Indian, who had type 2 diabetes because of their genetics, don't find their diabetes gets better as they lose weight. So that's the difference between the two. Type 2 diabetes, like all forms of diabetes, will have consequences of itself. So diabetes is an illness which causes a number of challenges to the human body. Most of the challenges of diabetes are because of excess sugar in the body. The sugar sticks to red blood cells, makes red blood cells less squishy. We need our red blood cells to be squishy so they can stretch themselves out and slide through little blood vessels throughout the body, because the smallest blood vessels in our body are actually smaller than the diameter of a red blood cell. So red blood cells need to make themselves all thin and sausage shaped in order to go through these tiny little vessels. If you've got too much sugar stuck on the outside of them, they can't make themselves thin and sausage shaped. They say it's a sticky ball, and those sticky balls damage the small blood vessels as they're traveling through. Those small blood vessels are in your heart, your kidneys, your feet, your eyes, which is why you end up with heart disease, heart attacks, kidney disease, kidney failure in some patients with diabetes, foot problems, including diseases like infections in the foot amputations, and blindness, which is why we do eye screening for people with diabetes. So that comes from the amount of sugar in the blood getting too high and it making the blood sticky. There are some immediate emergency complications of having a very high sugar level, but we're talking about chronic disease here, so we won't worry too much about it. The reason that people who are overweight develop type 2 diabetes is because the human body requires insulin to take sugar out of the blood and put it into storage as fat cells. As you gain too many fat cells, the fat cells release a series of hormones which make the insulin less effective, because they don't want more fat cells, because they're going, too many fat cells, stop making fat cells. So they release messages that say stop making any more fat cells. The problem is the sugar levels are high. So the body keeps driving more insulin out to say, no, sugar levels are high. You must make more fat cells. And that competition goes on. And what eventually happens is that the body runs out of the ability to make enough insulin to compete against that resistance that it's seeing from the human body. And that insulin resistance that the body develops is what causes the type 2 diabetes. Your pancreas, which makes your insulin, just cannot keep up anymore. And then your sugar levels go up and up and up and up and up and up and up until you go. Cardiovascular disease is caused by both obesity and diabetes. There's a double whammy for you. So the bigger you get, the bigger your blood pressure goes. The bigger your blood pressure goes, the more strain it puts on your heart, and the more likely you are to have heart attacks and strokes as a result of the blood pressure. Sleep apnea. Sleep apnea is an interesting one. I got some smiles in the back of the room. People, you don't have to tell me your own stories, but I suspect people have therefore come across this one. So firstly, to note sleep apnea. Sleep apnea has an O after the N, unless you're American, in which case it doesn't. So if you're ever looking this one up in the press, watch out for the fact that the Americans spell it differently to us, because they don't like putting O's in words, apparently.
Silent O's, you're right. That's why they leave them out.
Instead, the American. But yes, just as a note, if you're looking up sleep apnea, it is spelled differently in the US to here, so you will see it written down differently, especially in the interweb if you go and looking stuff up. So sleep apnea and weight is an interesting issue. It occurs usually because of weight gain around the neck area. It is directly correlated with the collar size of the individual. So the increase in collar size makes you more prone to sleep apnea. It, as a result of the additional fat being deposited around the neck, it means that when you sleep, you don't breathe as efficiently as you should do. Frequently is associated with snoring, but not always. The two don't have to be together. And as a result of not breathing properly, you can get phases. Sleep apnea refers to phases of stopping breathing when you're asleep. You can also get just generally slowing of breathing when you're asleep. That results in a drop in the oxygen levels and an increase in the carbon dioxide levels in the human bloodstream, because we breathe to get rid of carbon dioxide and to get oxygen. So it causes a reversal of that. As the body attempts to correct this, it increases the blood flow of deoxygenated blood into the lungs, and the consequence, therefore, the movement of oxygenated blood out of the lung and back to the body. So it speeds the blood movement through the lungs to try and correct the fact that your oxygen levels have dropped off and your carbon dioxide levels have gone up. So it's affecting the heart's trying to compensate for the fact that the lungs are less efficient. That causes an increase in blood pressure in that part of the circulatory system. So it's not the blood pressure we measure on the left side of the heart, the big pumping chamber. This is the right side of the heart, the smaller bit that most people forget is there, but is there. And it causes what we call, therefore, right-sided hypertension, because it's the right-sided part of the circulatory system. In itself, right-sided hypertension isn't immediately as obvious. You can't measure it. You can measure it, but you can't measure it in the community. You can measure it in the hospitals. You have to put a funky probe all the way into the heart and measure the levels. The reason that it becomes important is that as the blood pressure goes up, there is a risk of damage to the lining of the blood vessels and the clots forming as the blood comes out of the heart and goes into the lungs. If those clots are big enough, they get stuck in the lungs. And you get something called a pulmonary embolus, which is a blood clot in the lungs. Blood clots in the lungs are dangerous, potentially fatally dangerous. As a result, sleep apnea is a known cause for sudden adult death in the population. And we are seeing increasing incidences of sudden adult death as a result of obesity-caused sleep apnea. We're going to come back to that, and that is also the reason why Agatha was struggling to sleep and feeling tired during the day, because she's using lots of energy up when she's sleeping. She's not sleeping properly. The sleep apnea stops you cycling through your 4 waves of sleep, so you don't sleep as well as you should be, and you constantly end up tired in the day as a result of it. So that's the sleep apnea conundrum. Osteoarthritis. Osteoarthritis is damage to joints and a failure of joint repair. So osteoarthritis is not, you might, or all of you, I would imagine, but heard the term osteoarthritis. You may also have heard it referred to as wear and tear. Okay, I know I'm on video, but I'm going to go on video saying that's complete bullshit. Please stop using that phrase. Osteoarthritis is not wear and tear, and the science is massively clear about it. Osteoarthritis is a failure to repair the day-to-day damage done to a joint when you are using it. We damage our joints every day when you're using them, and so the body has to repair them. What happens in weight-induced osteoarthritis is the daily damage that is being done is in excess of the body's ability to repair the joint. It makes a repair error, which then turns on the repair system to try and fix the repair error, which causes a repair error because the repair system isn't working properly. So it then turns on the repair system even more to fix the repair error. And you end up with this positive feedback loop that results in inflammation in the joint as the body throws resources, blood, fluid, and everything else into the joint to make it repaired. And that's what causes the irritation, the swelling, and the pain around an arthritic joint. So osteoarthritis is a repair failure, not wear and tear. As a consequence, the treatment, the flip side of it, is using the joint in a healthy way, keeping it moving and keeping it working, encourages a healthy repair of the joint. So the way to solve the repair error is to use the joint healthily. Now, we'll come on to needing to possible people needing help to do that. Thankfully, we've got people who might need help to do that yet. So we've got the ideas around that. But the point, however, is that if this was wear and tear, the way you solve something getting worn out if you're suffering from wear and tear is to stop using it. Because if you've got something at home that's wearing out and you use it less, it wears out less quickly. If you call it wear and tear, therefore, the obvious thing to do is to rest it and not do anything with it. That is completely the opposite of what we want to do. We want to use it in a healthy way. So osteoarthritis should not be called wear and tear, hence the reason I was rude when that came up initially. So please fight that for me if you hear that being said out there, because it's wrong. Put them towards me. But osteoarthritis caused by weight is certainly there. Cancers are the other one. Now, weight causes a series of changes throughout the human body, which can make them prone to developing cancers. It's taken a long time for science to understand why. There is no obvious reason why an accumulation of body fat should make the body more prone to developing cancers. Especially when cancers of body fat, which do exist, are not on the list of cancers that go up when you get bigger. It turns out that, as far as we can tell, there is a release of inflammatory markers from white cells throughout the human body that cause a lot of the damage associated with cancer production. So, white cells are in our bloodstream. We've got, if I take a blood count from a patient, and you will have been up to the surgery, I'm sure all of you, and had blood samples taken from the surgery. If you have a blood sample taken for a blood count, you have a tube of red and white cells that go off to the lab. There's something like 2.4 million white cells in one of those tubes. So you've got lots of them in your human body, vast numbers of these things floating around. There's a specific subset of them called T cells, the letter T cells, which is there to provide two focuses. Firstly, your background memory of previous infections that you have come across and points the body to fight those infections. So it's your T cell memory of, say, your childhood exposure to chickenpox that stops you getting chickenpox a second time, because you've got T cells floating around the human body that know what a chickenpox virus looks like and knows immediately how to kill it as soon as you come into contact with it, which is why you can only get these infections once, because once your body's learned how to do it, you can't get it again. It's T cells that remember that. T cells are also part of the process of destroying damaged cells. There's a specific subset of T cells called natural killer T cells. You can tell whichever scientist came up with this has been watching too many American movies. I'm being continued to have a go at the Americans. Natural killer cells are there to mop up damaged cells which shouldn't be there, that have lived their life, that need to go away and be replaced by new cells. It turns out that if you accumulate too much body fat, that it affects the way these natural killer cells work in two ways. Firstly, they release a series of little hormones that float around the cells. One of them is the tumor necrosis factor, and the other one is interleukin-6. So these are a series of hormones that float around the cells. It releases those, which cause you to accumulate more body fat. So the more body fat you accumulate, the more the natural killer T cells cause you to accumulate more body fat. Yeah, there's a thing, isn't it? And also they turn off the messages to destroy damaged cells around the body. And it's the failure to clear up the cell damage that occurs just by life that results in cells going through changes that turn them cancerous that would not normally have happened, because the body's own natural killer cells, the hoovers that go around picking these up, aren't working properly. They're too busy messing around trying to sort out your fat cells instead. This also means that as a result of this, there is a tendency as you gain more weight to upregulate your white cells to cause you to make more fat cells. If you lose weight, you don't downregulate. That level stays the same, at least for a fairly long period of time upwards. Which is why if you go on a crash diet and lose lots of weight very quickly, as soon as you start eating what seems like a normal diet, same diet as the next person's eating, your weight piles on and comes back up to the same level as it was before, because the body's inflammatory system is driving you to make those fat cells back up that were damaged afterwards, because the white cells are demanding that those cells should be there in order to keep the body healthy. They've made a mistake in the way they do it. That's part of the reason why you get the yo-yo effects from crash diets. So what cancers are we talking about here? Part of the reason that Agatha is female is that two of them of note are breast cancer and endometrial cancer. As a result, women are more prone to cancers associated with weight than men are, because I don't have a womb and I don't have breasts. Just a fact. That's the thing. It also increases your risk of colorectal cancers and increases your risk of pancreatic cancers. So that's cancers of the large bowel and cancers of the pancreas. Those, of course, will be present in both men and women. Now, for a long time, if you look at life expectancies of adults in England, women have lived longer than men for a variety of reasons, both physical and psychosocial and biological reasons. The numbers are flattening out as we move forward. in time, and it is likely that weight is the main reason for that discrepancy beginning to normalize somewhat, and for the life expectancy of women to drop to come closer to that of men. So unfortunately, women are going to be more prone to the life-threatening effects of weight. We'll come on to surgery later. Oh, hello, I've pressed the wrong button there. We'll come on to some of the surgery later. If I can go back to my slide. What's my slide gone? There we go. Sweet, super duper. Social challenges. This is not a minor issue here. The so-called fat shaming issues go on. There are also issues around job opportunities, employment. We know that people who have a higher body mass index, if you compare them with a bunch of equally qualified people going for a job, are less likely to get a job. And these are well documented sociological phenomena. So there is a negative social impact associated with being overweight or obese. As a result, people who are overweight or obese as a population tend to earn less than those who are not. And there is a corresponding reduction in job opportunities. Some jobs are not available to people who are morbidly obese. You can't apply to join the army if you're morbidly obese. They won't let you in. You can't apply to join the police force if you're morbidly obese, not as a frontline serving police constable. They won't let you in. You can't apply to join the fire service if you're morbidly obese. It's an exclusion on the job application form. And there are many others that go down the list where weight is a barrier to access into those jobs. So as well as being generally lower earners, there are also a whole bunch of job opportunities that are not available to people who are overweight. And in terms of economic burden, well, I talked about some of the numbers earlier on about the huge number of money that we spend, but let's think about hospital admissions themselves. This is numbers which are easily available because NHS England publish these all the time. We were looking at not last year, because last year's data isn't out here, so it's the year before last. There were 1.2 million hospital admissions in England that were directly attributed to weight as the reason people going into hospital. And we're overrun with hospital beds, aren't we? I mean, the waiting lists are virtually zero. That's fine, isn't it? That's not causing us any problems. That's it. So yes, combating that certainly would have an impact. And if you want to bring hospital waiting lists down, obesity is a pretty good target for you to be able to do that. Yeah. Anybody got any comments on what we just talked about so far? So if we think about Agatha, she's got ancient pain, probably due to a bit of arthritis. She's having problems moving around. She's getting so her occupational issues are not about paid employment, but are about occupying herself. She's having problems with childcare. She's feeling tired all the time because of her sleep apnea. She's got poor sleep at night. She's waking frequently. She's probably got some mental health problems as a result of all this. I mean, if you're living with all of this, you're going to start to feel a bit down, if not be depressed by this one. So go.
So you were talking about the social impacts. I worked at the John Radcliffe for 4 years, and in that time, it got harder and harder to buy healthy food because we basically contracted out the catering to Marks and Spencer's.
Yep.
So if I wanted a snack or something, I had to go and buy their hugely expensive UPF.
Yeah.
And I would say that's a general trend. You go to Costa or places like that. Yeah. So it's actually a social barrier to weight loss.
Yeah. Yeah, absolutely. And it's something that we've seen it in the hospital, certainly as somebody who's been around hospitals a lot, of course. Yes, you are right. When I first started working in hospitals, there was I think it was a spa in the hospital, but it was just it was like you would expect a small version of the corner shop, and you could go in and you could get whatever you wanted for that. By the time I finished, this was University Hospital of Wales, by the time I finished, there was a McDonald's in the hospital.
Yeah.
Oh, God.
Yeah.
Yeah.
Yes. Yeah. We'll look a bit about some of the policy options that will come around that later on. But you are right. These were not particularly clever ideas in retrospect, were they?
Well, because, sorry to elaborate, but apparently Bevan, when he was introducing the health service, his belief was that by preventing illness, there would be no need for a National Health Service.
Yeah.
But because it hasn't taken those preventative measures, and ironically, the NHS is at the forefront of not taking preventative measures,
Yes.
you've ended up with these huge waiting lists.
Yep.
He wants to be up front because that's the message Bob is saluting.
Yeah, no. You're absolutely bang on.
No, you're quite right.
You've absolutely nailed exactly the argument that we're starting to make here. The NHS has failed to deliver, not the least of which is sometime. I can't remember when the split occurred, but at some point in the 60s or 70s, public health was split away from the NHS. So the policy to control this, and there will be some slides at the end when we talk about public policy, but the public policy to control weight is divorced from the National Health Service. We don't have a National Health Service anymore. What effectively we have is a National Illness Service. I'm employed to treat sick people and make them better again.
Yeah. You're incentivized by ill people.
Yes, I am. Yeah, absolutely. The more ill people I have on my books, the more money I get paid.
Okay.
Yeah, absolutely. Yeah, that's very much exactly what we are in at the moment. And that's the nature of the way the NHS is set up at the moment. I am not incentivized to prevent people getting sick.
Yeah.
No. In fact, to some extent, the other way around. The more people with diabetes living in Faringdon registered with me, the more money I make, because I make money treating people with diabetes because I'm paid to treat people with diabetes and I get paid for their event. Yeah. Mm-hmm. Yeah. It's not difficult to realize that this doesn't add up, doesn't it? Let's talk briefly about the NHS treatment pathways, and we'll see if we can make Agatha better with what we've got available to us. So, 4-tier approach to the treatment of obesity in Oxfordshire. So, the first of those is, unsurprisingly, Tier 1. Tier 1 is actually not a treatment. Tier 1 is the public health campaigns that come out of Oxfordshire County Council to reduce weight gain and to encourage people to think about weight more. It also includes, listed in Tier 1 is things like brief intervention and advice from GPs and GP surgery. So this is us spontaneously pointing out when people come in with a thing that isn't related to weight that perhaps we should be doing something about the weight as well. So Tier 1 is around that. It isn't funded by the National Health Service. Tier 1 is funded by Oxfordshire County Council through their public health budget. And they have a delegated public health budget. So they're given a block of money, Oxfordshire County Council, by the government for spending on public health. They can't siphon it off and spend it everywhere else. It has to go on public health. And they can add money to it, but they can't take money out of the pot. So that's the people who spend money on that. You will have come across the over 40s NHS health check. Some of you may have heard of this. The over 40s NHS health check is not an NHS health check. The over 40 NHS health check is provided by Oxfordshire County Council. It's just nobody turns up to the over 40s Oxfordshire County Council health check, and everybody turns up to the over 40s NHS health check. So they just nixed the NHS brand, stuck it on there, and sold it off. But it's actually not an NHS health check. And in many places, it's not. We provide it in the surgery in Faringdon. It's funded by Oxfordshire County Council, so we get an additional funding stream to be able to provide it there. If you, for instance, you go to Wantage, it's not provided in the Mabley Way Health Centre. Their health checks are provided by a third-party organisation funded by Oxfordshire County Council to do their health checks for them. So that's the Tier 1 service, which is all about that. It also encompasses, to a lesser extent, work in schools. And there is some money put into, not a lot, but there is some money put into schools to talk about obesity and other bits and pieces. Remember that Oxfordshire County Council also, of course, funds schools. So there is an overlap between the two of those, and they can sometimes wiggle some money between both of them to see what we get. In theory, Tier 1 also includes other aspects socially, like housing and development, and developing houses in a way that promotes activity and not a sedentary lifestyle. That is theoretically part of the Tier 1 plan. Now, that's not Oxfordshire County Council, that's the Vale of the Whitehorse District Council. Now things get even more fragmented, of course, and they actually don't have any money to do that, Oxfordshire, the Whitehorse District Council. They're just expected to do it from within the funds that they've got anyway. Yeah. And when was the last time you saw a planning commission that said, this block of houses will result in people being less overweight. I mean, it should be there. Theoretically, by statute, it should be there.
So we used to live on a housing development in York that was sponsored by the Joseph Rowntree Foundation.
Mm-hmm.
And one of the things they did was reduce the amount of parking available,
Mm-hmm.
so that the theory was we would all have to walk, cycle, or catch a bus
Mm-hmm.
instead. Actually, all it resulted in was very dissatisfied citizens.
Yes.
We
Yeah.
also got given money to buy a bike when we moved into the house.
Yes. Yeah.
That was Joseph Rowntree.
Yeah, that was the Joseph Rowntree stuff. Yeah. No, the first part about parking hasn't worked. And the research, there's not the only, Rowntree wasn't the only foundation that did this. There were others as well. It sounded like a good idea.
Yeah.
So I get what they're trying to do, and trying is always a good thing. So I'll give them bonus points for trying. It didn't work. The bike thing actually did make a difference, and we have seen this in terms of reducing sedentary lifestyles and encouraging people to move better. And as much as I will whinge about Boris and his time as Prime Minister, especially during the pandemic, where frankly he made a massive balls up of the whole bloody thing, the Boris bikes in London have had a significant impact in the number of people who are cycling. We are hopeful that as the price of things like electric bikes comes down, and they are coming down rapidly, that the ability to use those as a way of commuting at least shortish distances could be a thing which is useful as well. So we have begun to see some of this. So the bikes with houses was the start of a trend which has continued and been built on. So whilst the car thing didn't work, Rowntree did win with the bikes thing. So
Well, it also worked really well because York is a cyclist city.
Yes,
and that's
yeah,
the other thing that needs to be considered.
yeah, no, I've got one of my family's just finished a master's in York, so we've been up and down from time to time. I like the city, but you're right, it's nice to cycle.
Do you think we could get the Vale to sort out more cut-throughs through the new estate so that people will walk and bike and not take their cars
Yes.
from one side of Faringdon to the other?
Yes, I found the Vale to be very sympathetic, and I've spoken to them about this before. It's not unusual. People may well know that I know Bethy and Lucy, the two Vale district councillors, reasonably well, and I have met and worked with the other Vale district councillors for the catchment area, not least of which at least two of them used to be vaccinators in the health centre with us. So we've known each other for quite some time now. I found that the councillors to be very sympathetic to that, and the planning office in the Vale and Whitehorse District Council is extremely sympathetic to that. Some of the challenges are around the discrepancy between what they want to do and nationally what they are legally being allowed to do with housing development. Because of course, housing developments are driven by the Minister for Housing in Westminster, who's decided that we're going to earn lots of money as a country by building lots of houses, because they've gone down this Keynesian approach of building houses to make money. So they're less worried about the cycle pass than they are about the number of bricks put on bricks, and that's been a bit of the challenge. But yes, I do find that the Vale is very sympathetic to that. And actually, if the patient participation group or patient group themselves wanted to lobby their councillors, I would encourage them to do so. I do, but I'm just one voice and one constituent, or a fairly loud one's a GP, but it's just my voice. So the more people who mention this to them and make it a priority for the politicians, the more likely they are to think about building in a way which reduces the sedentary lifestyle and encourages people to move more. And it doesn't need to be lots. I'm not talking about running half marathons. I mean, you're welcome to run half marathons if you want to, everybody. That's fine. But you don't need to do that. That's not the kind of moving that we need. Actually, just, walking from the new estate down to the town to buy your shopping and walking back again. It is a fairly easy way of managing to get those things moving. So the tier 1 stuff can work really well. It's just a bit disjointed in all over the place at the moment and lacks that sort of strategy that pulls them together. Tier 2 is, I think this is listed as, there you go, lifestyle weight management services. God, there's a label for them. So this is lifestyle programs including diet and exercise to support weight loss and encourage activity. Beezy is 2 now, or you are 2, aren't you?
We'll let the two.
The 2. Okay, because I keep moving these things around so quickly. I've lost track of them. So this is supported weight loss, so supported diet change and supported activity increase, especially for those people who have become anxious, concerned. I mean, her head is struggling to get right at the moment. And so she's going to need some help to increase the amount of activity because it hurts when she moves. She's going to need some help with diet because clearly she wouldn't be 150.4 kilos if she knew how to adjust a diet in order to lose weight. Otherwise she wouldn't have done it by now. She knows that that's big. She knows that's wrong, but she doesn't have the handles to and the confidence to make the changes that she needs in order to get things moving forward. She's got those really important things she wants to be able to do, which is to look after her grandchildren, but she's got no confidence to make the changes that go forward. So what Tier 2 does is attempt to instill some of those confidence in people. Also inside Tier 2, we'll talk about some of the bits you do just in a moment. It includes the psychological services. So there is a branch of the talking space, so the talking therapy services, the NHS talking therapy services, specifically for people whose mental health problems are either being driven by their weight or are driving their weight, or more likely both at the same time. So looking at helping people's mood as a way of helping them to be more confident about engaging in weight processes. You don't have a psychologist, do you, in your service?
We don't deliver the talking service.
No, okay. There's certainly it is. I know the self-referral patients can just ring up the talking therapist phone, the NHS talking therapist phone number, and the team's run by Minds, the mental health charity. They're really very good. So they make a huge difference. Patients do respond very, very well to it. So we actively encourage that a lot, and then we also actively signpost. So that bit about Tier 1 brief intervention, GP going, you do know you're a bit big, don't you? And they say, yeah, what can I do? But what I can do is yourself. Do you want to tell us a bit about what you do? Is that, yeah.
Yeah. So I'm part of the Beezy weight management service. Weight management, Beezy, BWZWE. If you look up BZ Oxfordshire, you will find us online. You can refer anybody with a BMI of 27.5 or above is eligible to join us, provided they meet other criteria as well. But if you're welcome to refer yourself through that system. You can get referrals through other routes as well. But yes, we're just funded by Oxfordshire County Council, and we're just providing that service across Oxfordshire.
When is it past Oxfordshire?
So your closest groups here are Wantage on a Monday evening, Whitney on a Wednesday evening, Abingdon Thursday evening, Didcot Friday morning, Kiddington Saturday morning. They're the closest groups. But it's free of charge to people to come along.
I'm in the middle of one of them.
Are you?
I'm on the online, it's called Gutless.
Yes.
Oh, yes.
Yes.
That's the 4 men one, isn't it?
Yeah, it is. It's good.
Activity, we have physical activity involved with that as well, so that you can actually get involved with some exercise routines during that session, which are definitely rigged to your particular needs. So we often have some in the same group that are seated and standing, and some that are sweating buckets, because it's all designed for each individual. So the courses that we run, the weight management for adults that we run, are in various parts of the county. They're a 12-week course. The first touch point of the 12 weeks is an initial assessment over the phone, where we get some basic information from you, and then you go to the adult weight management course, and it's 10 usually consecutive weeks in 2 parts. So the first part is looking at healthy changes that you can make to your diet and lifestyle. And this is a habit changing process, so we always look for the habits that you can change, and we give you the skills and tools on how to implement new habits and get new habits ingrained in your daily lives. So they are taking you through from basic nutrition through to portion sizes and to navigating the supermarkets with food labels. We look at the psychological side of how, if you can get too hungry, you will get hangry and you'll start getting cravings. And we point all of these things out. And we go right through the sort of different healthy snacks that you could be going for, what you could look for if you go out to eat. So each session has got different information, and then we have support systems with WhatsApp groups in between the sessions. And although this isn't looking for active weight reduction during this time, this is for habit change, this is for making lasting changes that are going to stay with you. We do find that the majority of people that are with us over the course of the 10 weeks for the live face-to-face sessions usually lose about 5% of their body weight in that window. And that's just really trying to give them all the tools that they need to take that forward, after the session has concluded. So that's what we're offering.
We like it. It works. So that's tier 2. Which is very, very effective. Tier 3. So what we've done is we've sorted Agatha out. We've done whether they're probably online to start with because she's probably not getting out very much. But Agatha started on the tier 2 work. She's gone to she's speaking with the psychologist. She's doing some more movement. She's doing some work with the online team to increase the amount of movement and the confidence she's got in the movement. And she's doing some work on weight as well. What we now go on to is tier 3 stuff, which is the specialist weight management. Now, there are various parts. Again, this is a bit fragmented. One of the things I'm going to have to do as Agatha's GP is to refer her in to get a sleep apnea looked at. Now, that isn't done by any of the weight management services at all. That's done by the sleep clinic in the hospitals, because why would you want to join these are? So one of the things that we'll have to do is to refer her into the sleep clinic. So we'll get Agatha on some treatment for her sleep problems. That would be the tight-fitting mask that she has to wear when she's asleep in order to help her to breathe easier. But the consequence of that is that we will manage to resolve this for her. The other thing I can do is refer her into tier 3 services. Except I can't. Because the NHS Integrated Care Board for Oxfordshire, who have all of the money for health for Oxfordshire, have spent all of the money on tier 3 health that they are allowed to in this financial year. As a consequence, I can't refer anybody for tier 3 services beyond the sleep apnea one because there isn't no one to refer them to anymore. Now, apparently they're going to get that back for us. Who knows when? They didn't give us a timetable on it. When I could refer them for tier 3 services, what the patients got was a further extension, effectively a personalised version of the work that BC were doing, just a one-on-one rather than in a group, and access to weight management therapies, the prescribed weight management therapies. And we'll briefly talk about those in a moment. But this is the, skinny injections. So they're on the next slide, by the way, the skin injections. So we send off Agatha to all these bits and pieces. She starts on her weight loss injections. She goes off to her therapies. She probably has some one-to-one therapy, as well as the tier 2 to support in the background. After a relatively short period of time, we would expect Agatha, no more than 3 months, to be able to move better. She's got less aching pains. She's feeling much better about things. She can do the housework and prepare the house for the grandchild to arrive. She can pick them up and walk around with the grandchild. Big win for Agatha. She's really happy with that. She's far less tired and she's much, much more positive. As a general rule, by doing tiers 1 through 3, what we have done is make Agatha less diseased. She is much better in her life than she was before. Agatha's weight at the end of this process, 3 or 4 months down the line, is almost certainly 150.4 kilos. Because there is no evidence that anything we have done down here will make any difference to someone whose weight is already that size.
She's on injections.
She's on injections. They don't work if you're that big.
This is a tier 3 injection.
Yes.
Oh, it's going to
Yeah.
GPs can prescribe them.
There's a thing.
There's no money for
No, well, not quite yet. In order to prescribe it, the patient needs to have a BMI over 40, needs to have a cardiovascular disease that is established under treatment, needs to have a high cholesterol, which is established under treatment, and needs to have hyperobstructive sleep apnea. Assuming that she has all of those, I could be prescribing Agatha weight loss injections. I could do it. They're not going to work. Because once your weight gets that big, they don't have the impact. The only thing that would work for Agatha to reduce her weight and the reduced risk of diabetes and all of those cancer risks that come with the weight, is tier 4, which is surgery. Someone who gets to Agatha's size will only respond to gastric surgery in one form or another, either banding or sleeves or bypasses. But they are going to need weight loss surgery, or Agatha's weight is not going to come down significantly.
What's the BMI or weight cutoff?
There isn't really one. I can't remember. I think weight loss surgery is over 45. It's a variable feast. There are other, if I can rack up the things that are going wrong with the patient, I can push the weight down a bit.
Yeah, but that also brings in a lot of other complex problems with the bariatric surgery, general anaesthetics.
Yeah, you'd think so, wouldn't you?
Yeah.
Yeah, actually, but the evidence base is categorically clear. She's probably going to be fine from the surgery.
Oh, right.
It's actually not that hard to do. It's robotic these days, so it's not big holes. It's done
Private
through
practice.
keyhole, and it's done with a robot.
Oh, I don't know about that.
Would private practice have a lower BMI acceptance?
But private practice can do whatever they like, whenever they like. It's a human being.
The
Yeah.
NHS have set this very
Yeah,
high.
yeah.
So,
And now, well, the NHS is set, not only does the NHS set a very high service, it's also closed it. The service in the Churchill isn't there anymore, it's gone.
yes.
So the nearest weight loss surgery service I can access for my patients is in Luton.
So the barrier. My God.
Agatha can do that way if she had a better diet.
Yes.
Correct. No, you are almost certainly, because of the changes that have happened that we've already talked about, because weight drives weight.
Okay.
She's got to the point now where if she eats enough to keep herself alive, because she needs to eat enough calories to keep herself going, because Agatha's so big that her calorific demand just to survive day to day is going to be quite high.
Yeah.
As soon as she gets near enough to that to not make herself ill by dropping down the diet so low, she will just store as much fat as she's using up. She's in a cycle now, and she's got that big that she can't break out of without the surgery to break it. Yes. And that gap of the tier 4 services is one of the big challenges that we get because it works. It is safe. It is effective. The response is phenomenal. 65% of people of Agatha's weight who go through surgery will stop being diabetic. 64% of them will stop being diabetic, and I can't get them into the surgery. Grr. And as a former surgeon before I became a GP, it is utterly frustrating that clear, effective surgical choice is not being made available to the patients. Sorry, I'll go off my hobby horse here.
Is there a threshold point at which point it's bariatric?
Yeah,
level 4?
there is. It's a little more complex than just the BMI because you need to, as I said at the start, the BMI isn't actually an exact science. So we actually take into account a bit more of a picture. So there's a holistic patient-centered picture that comes into play, and there's a scoring system that goes with that works out whether they should be suitable for the tier 4 surgery or not. But even if I do score them up for it, I can't get them there.
Oh, so what sort of weight do you use of them out for?
About that sort of weight. It's very big. Yeah. You're talking about, what did you say? You said 23, didn't you?
Yeah.
23 and a half.
23 and a half. So 23 and a half up to 25 stone, that sort of weight range would get you into the sorts of numbers that we're talking about here, but very big. Yeah.
So sorry, being remorselessly pedantic here. Below that, you can still recover another needs.
Yeah, there is a threshold that you will pass over. It varies slightly from human being to human being. But once you pass the threshold, you pass the threshold.
Yeah.
Things had changed. I mean, we used to have to go tier 1, tier 2, tier 3 before I could get into tier 4. And you had to gateway through all these tiers. At least they'd recognized that the science is what the science is now. And now if somebody is that big, I can just go straight to tier 4. I wouldn't do it. I would put the referral in whilst doing all of the tier 2 work and the tier 3 work, because that supports all of these things getting better, which is what we said. We make Agatha less diseased by doing the tier 2 and tier 3 work. We make her weight come down by doing tier 4. So they're not one step on another. They are parallel strands that should be happening at the same time.
But you can't get it.
But I can't get it.
The wobbly web says Gloucester has it, NHS.
Yeah, it does. Yes. Gloucestershire won't let Oxfordshire refer.
But you can't refer to them.
No. Yes. GLP-1 receptor agonists. So, GLP-1 receptor agonists, are the skinny jabs. These are the things that you've seen all over the press. So there's Mounjaro, tirzepatide, the two names of the same thing, and Wegovy, I still don't know how I'm supposed to pronounce that word, Ozempic, which is the other name for it. Now, Ozempic also has a third name, semaglutide. That's only used for diabetes. That's not used for weight loss. Although, of course, if you use it for diabetes, there's weight, but that's a separate side. So what these do is these are agonists. Agonists are things that stick onto proteins in the body and agonize them. They effectively block them, stop them working. So these are going to go along. They are going to stick to the glucose-like peptide 1 receptors throughout the human body. Remember I said back at the beginning that hunger is a hormone-driven sensation. By sticking onto the GLP-1 receptors around the body, you stop a human being feeling hungry.
I have a question. Does that but that doesn't, if you're eating because you're not hungry.
Mm-hmm. Yes. Yeah. That won't work. You're quite right. Yep. Yeah, no, so it's not universal. It doesn't work for everybody. You bang on. And I do have patients who we put on this who have gained weight for exactly that reason, because they're not eating because they're hungry. They're eating because they're eating. Yeah. So you won't break that. You will only break it in people who have got a hunger-driven challenge to what is going on.
And as soon as you stop it, you get hungry again.
As soon as you stop it, you get hungry again.
And so, unless you change your habits,
yes,
it's going to change.
Yes, absolutely, bang on. You've nailed it. So there's no point in doing this unless you do that at the same time.
But does the hormone that makes you hungry sort of settle down if you get used to being hungry?
No, it doesn't. It comes back again. As soon as you stop the drugs, it comes back again. Like
go through the hunger.
Yep. Yeah. So in order to do this, what you need to do is to take the drugs, give you a window of opportunity to lose some weight, gain some confidence, and do the work that BZ are offering with patients. This is back to my tiers and not steps. They are parallel lines that we should be doing at the same time. We should be doing BZ and tier 3 at the same time. The problem is at the moment is I can't get hold of the bloody drugs because the NHS won't let me prescribe them to people because it's worried that I'm going to break the bank by prescribing it all over this place. Now, these drugs are not without risk. There are very serious side effects if you get this wrong. You can kill people with these drugs if you get them wrong. Thankfully, we've not done that in White Hills medical practice because we take care to get it right, but they are not the sort of thing that should be just lobbed around all over the place. Unlike the fact that they are at the moment in the private sector, and some people can have some really serious side effects associated with them. They do not suit everybody by any stretch of the imagination, but if they do suit them, they work. So if you find the right patient and you get the right patient on these drugs, they work. And for most people who are around that body mass index of 30 and climbing to 35, 40, they are massively effective. And I can only prescribe them to people with a body mass index of 40 and above, where they are less effective because they're approaching Agatha's problem. So we're targeting the wrong sodding group.
That's powerful, of course.
Yeah, welcome to NHS. At the moment, everything is becoming a little bit limited. Now, we are hoping that we will, with time, get access to more of this. We have a former health coach who was actually a nurse, a research nurse in the White Horse Medical Practice, interested in taking this on with the patients. So hopefully, as the NHS starts to open this up more, we will manage to get more and more of those tier 3 services through the White Horse Medical Practice, supported by the tier 2 services running at the same time with the patients. And I think we can make a significant difference here if we can get that to work. I'm hoping that in April, the next tranche of money comes through and we can move that forward. So it's not a million miles away. Cool. Oh, and then there was a brief bit I was on bariatric surgery. We've already covered that one. Fabulous. So prevention in the 10-year plan. There is some bits and pieces about stuff in the 10-year plan. Junk food advertising. Apparently it is going to be stopped. Although they don't actually define what junk food is. But apparently there's going to be a ban on junk food advertising. This follows a similar strategy. We saw a ban on smoking. Cigarette adverts were banned. And as a consequence, cigarette smoking went down. Several things were banned, but it was one of the many things that was done to reduce cigarette smoking issues. So a ban on junk food advertising makes sense. That follows a strategy that has worked previously, if they can pull it off. The other one is that there is supposed to be, and I'm going to have to look this one up here, is the Obesity Pathway Innovation Program. There you go, the OPIP. That's catchy, that, isn't it? Yeah. Sweet. Super duper. Which is supposed to be using high street pharmacists to make everybody thin.
How?
They didn't say.
Shutting her time.
Pass. No idea. Because our high street pharmacists have got loads of spare time floating around to do this as well, haven't they?
Yeah, absolutely.
Yeah, and bear in mind that we've only got 2 high street pharmacies in all of the catchment area of the Whitehall's medical practice. Yeah, we go up to Appleton, we go down to Avon Bridge, we go over to Gloucester, we go up to the White Horse. It's and there's 2 pharmacists. There's the 2 in town. That's it. We are the pharmacist for the rest of it. Yeah, so I'm not quite sure how the OPIP's going to work, but that's a thing that's going to be happening, apparently. They do talk about integrated public health strategies. And actually, on this one, I am more positive. If they can pull this off, if the government can pull together the public health strategies for obesity across all of those fragmented strands I have highlighted throughout this evening into one place, one person responsible for making this work, responsible to the electorate for making this work. We are a democracy after all. If we can pull that off, we might be able to make some progress. Hopefully, that's what is going to happen. That looks like it's what they're going to happen. And then, of course, because this is a Wes Streeting thing, apparently AI is going to make everybody thinner. He didn't say that.
So we won't be able to go, it says reduce the GP burden, so we won't be getting the GP to...
well, in theory, if you make everybody less heavy, then there's less work for me to do.
Yeah, so we won't be getting it there.
But I'm the one who's going to be doing the work, so how that's supposed to work out, I don't know, because I'm supposed to be the one making everybody less thin, but reducing the amount of, making everybody less overweight, but reducing the amount of work that I do at the same time. Yeah. No, that doesn't matter.
I need to bring in contracts with patients, clients, and say, if you're going to do this, then what you need to do is you're going to be given the drug. You've got to sign up with the BZ.
Oh, that is already the case. Yeah,
You can't
the current ones, the small number of patients that do meet the criteria we have at the moment, which is frighteningly few, have a clear instruction. You get this drug as long as you engage. If they don't engage with the BZ process, then the medication is stopped, and that's clear, because we know that these 2 strands must run together for this to work. We make people less diseased by doing all of the work. We make people lose weight by giving them the drug, and then they sustain the weight loss because they are confident in their new lifestyle, because BZ has made them confident in their new lifestyle. That's the bit that's going to add up to make the difference. And that's the bit about the future directions here in this comprehensive obesity management, not talking about tiers and steps, but talking about parallel pathways which are running together and are all communicating, working together. Whether it's funded by Oxfordshire County Council and the NHS, we need to get that all plugged into one space so that the weight management processes are all moving forward in parallel to each other, and holding each other's hands as we're moving forward. If we do that, we know how to make this work. We know what good looks like. That bit's now solved. And that's relatively recent, of course, because we didn't have the drugs until recently. Cool. Fine. I think that's probably enough, because I'm going to be told off by Sarah for overrunning the words.